watch the enteral feedings, you want to know for the NG tube what that is. We'll be asking you what range is low intermittent suction when you come in. So you're making sure that that's good and that you are seeing stuff coming up through our NG tube. Then at that point you want to clamp it, because the rest of this you want to make sure that you're doing with it clamped. So that when you clamp this, you want to make sure that you're kinking the tubing, you have gloves on, you're going to disconnect it from this suction, you're going to go ahead and hook this up. And normally I'd be on that side of the bed, so do you want to go ahead and just put this over there, and then you would turn off your suction. So now we're ready to start our assessment on our patient. So I start with the far wall, and then I always go down to my patient. And I look for safety things. I make sure that her NG tube is got a safety pin to her gown. Otherwise, every time she moves her head, it pulls, and it will gag her when she does that. So then I will start with the tube itself. I will make sure that the tape is nice and secure. I look at the nose. I'm looking for any type of skin breakdown around the tape itself. Then what I do is, usually they'll tell you what the markings are. So I will look to make sure that this is marked correctly, that it hasn't come out. So it'll say, I don't know what this is at. 50, 49, 48, 47, about 46 centimeters at the nose. So that's what they're going to document. You want to make sure that that is there. Sometimes they'll put a piece of black tape, or they'll mark the tape so you know, and if you see that mark falling down, you'll know that that NG tube has come out. So then the other thing I will do, I'll have the patient open her mouth, because I want to make sure that it's not coiled in the back of her mouth. So, okay, good, that's not coiled in the back of her mouth. Now there are couple of different tests that you're going to be doing when you're in the patient's room. One of them, and generally, it depends on the policy of the facility that you're at. So again, you have to follow whatever they do. I'm showing you a couple things. One thing you would do is you could check the chest x-ray to make sure the NG tube is placed correctly. You could also look at the gastric contents to make sure that it's gastric contents and not something else on the stool. So I'm going to sneak around you, because I really have to be on the side of the bed to do this part. And then I'm going to go on the other side when I grab my meds. So we would put a pH paper in here. You want to hand me the pH paper? It's up. Yep. Because I always kind of do a couple things at a time. So I put the pH paper inside the emesis container, and I have gloves on. I'll just put them on so you guys can see. You're all larges. We must be out of mediums. My hands must be getting bigger. So I will put 30 cc's of air in here. Again, I'm going to kink this because I'm opening this up. I'm going to attach my syringe to this, and then I'm going to go ahead and I'm going to listen for bowel sounds. So I'm going to do my abdominal assessment, which is what? What do I do?
Right.
Four regions. You auscultate in the 4 regions.
Before I auscultate.
Inspect the area, look at it.
Now, would I put her flat? Anybody who's been tube fed, you never put their head in bed less than 30 degrees. So this is one where you would have to inspect it from 2 different angles. And I don't need that open. Making sure, what are we looking for? Distension. We'll ask her if she's having any type of pain. So then we would go and we would listen to the different quadrants, 2 to 3 spots for 1 full minute. I'm not going to actually do that, but so 2 to 3 spots. The next thing we would want to do is, ask her for pain, and if she's having pain, we would palpate to see if we feel any masses or if it feels more distended to us. The next thing we're going to go ahead and do, we're finished really with the abdominal. We're going to tell her, I'm going to listen to your apical pulse for 1 full minute. You will take a pulse for 1 full minute, making sure again it's above 60. So I'm going to go ahead and, actually I still need to leave this up, because now I start with the NG tube itself. Some facilities, they want you to use a swish of air. So again, I have 30 cc's of air in here, so I'm going to swish it really fast. And you should hear a gurgle in the stomach if it's correctly placed. The next thing I will do, because now we are finished with this, now I'm going to check her residual. So I will pull back to see if I get any fluid from her stomach. And you should get something. If you truly get nothing, it's probably plugged. But you should be able to get a couple of drops. How much fluid do I pull back?
Until you feel resistance.
Until you feel resistance. Because you want to make sure you get all that residual out. What basically you're trying to make sure she's tolerating the tube feeding. And usually at most facilities, every 4 hours you're checking to make sure that this NG tube is properly placed and that you're irrigating it. And anytime you irrigate it, you need to make sure it's properly placed because you don't want to put that into the lungs. So we'll say that we got 60 cc's on here, and that's all that we got. So then you're going to put a couple, just a little couple drops on your pH paper, and then what do you do with this NG fluid? You note that how much is in here.
Yeah.
You check the pH. You put it back. If it's more than 1.5 times, and again, this is our facility policy, usually 1.5 times you're holding the feeding, but we're going to put the residual back in. We'll say it's fine. So if we're giving 150 milliliters, how much would 1.5 times that feeding be? 225, because half of the feeding is 75, adds that to the 150, and that's 1.5 times. So we put that back. pH, I'll ask you about what a normal pH should be. So we're going to compare our pH to make sure it's accurate. Again, that's another check. So we've done like different checks. We've checked the chest x-ray, we've checked the placement on the tubing, we've done an air swish, and then we've also done the pH. So we've done 4 separate checks. Normally, you would only have to do 2, or again, follow your facility policy to make sure that you're doing it correctly. Now the way that we're going to do this is we're going to do everything by gravity. So, I'm going to grab this with me. This is the part where we're going to go to the sink. We're still right here by the patient. Remember, we're not leaving our patient. We're not moving anything. We're staying put. Is this plugged in? So when we go to the sink, we're going to make sure that this is not in this container. Some people have done the checks here, but to me it seems more real if we do everything for the patient at the bedside. So what do we need to do next? We need to do our 3rd check. So what I'm doing is we've already compared the wristband to the MAR. We've already done that. So now we need to do our 3rd check with our meds. So this was the Gevity, and again I would have my label on here. So we have metatarsal, 62188, metatarsal 62188, no known allergies. So I have my Gevity 150 milliliters bolus. And remember, we won't have the container in here. We have our label that we're comparing it to. So we have that done. Then we have our metatarsal 62188, metatarsal 62188. We have digoxin 0.25 milligrams daily per NG tube. I'm sorry, I pointed to the erythromycin. So this is our digoxin. All right, so then the erythromycin, metatarsal 62188, 62188, erythromycin 500 milligrams, which is equal to 1 milliliter, and then we filled it the rest with fluid. And it's NG tube at daily, so it's just one time. And then this is our free water. We started with 500. I'm down to about 475 right now. So I'm going to go ahead and we're going to get ready to give it. So when we do this, there it is. When we do this by gravity, and some of them will just, some facilities, they pull it up and they go ahead and bolus feed, and then they keep drawing it up till it's in, but we're going to do this by gravity. So we're going to go ahead and open this up. We're going to put our syringe on. Can you guys see back there, or do you want to move up? You can move up closer. So I'm going to leave this open, but I'm going to kink the bottom of the tube, because I'm going to fill my syringe, and there are ones that have darker markings on them, so we'll have to find those. But you're going to fill this up to 30 milliliters. And then we're going to go ahead and let that go in. As that gets near the bottom, I'm going to give the digoxin first. If this needs to be stirred, I would have a stir stick here, and I would go ahead and, I must have kinked it really well. This is good troubleshooting, so I may have to just put this in.
I wonder if there's like clogging up, is the tube clogged out? No.
Not now.
Yeah, there you go.
So then I'm gonna go ahead and put my digoxin in. And let that infuse. And between meds, you need to give 30 milliliters. It's draining, it's just taking a little bit. And before the end of that is when you will add your 30. These seem smaller. Do we have smaller tubes?
You know what, they are, Chris, they're smaller ones. That's probably why it's going so slow.
So before this is over, we will put the erythromycin in. You don't want a lot of air going in between. And I can see it's already going through. So then I'm going to start my Jevity feeding.
You wouldn't put water in between the medicine and
You
the
don't
Jevity?
have to,
Okay.
because we're not, it's just food.
Okay.
So it's okay. You don't have to do it between the med and the food, but between the meds you should. And if meds are the only thing you're giving, make sure you flush that tube, otherwise it can get sticky. And you never want to let this fill all the way up, because if he were to belch or burp or have
Come
gas
over.
through it, it'll come up and over. And I have seen it happen. Now, if you go to give the irrigation, you're going to find out a couple of tips on what you should do, so make sure you pay attention to that. I'll be asking you what happens if you figure out that none of your fluid is going through here at all. And this is in a patient, not in the sink. So I want to know what your actions are going
That's
to
what I
be.
was gonna say, so where does that go in over there, like that?
In the nose, in the tube in the nose. Same setup. See, I
Oh,
have,
right,
this is
right
just the
here.
tube, yeah. And some patients don't have NG tubes, they
Mhm.
have G tubes, gastric tubes. Alright, so I need to give 30 cc flush, plus I need to give the 100 cc's. So right now I am at 300, 350, 375. About 250. Because you can't measure 5 cent. So before this empties, I would go ahead and I'll put it up to 60 this time. And of course you're talking to your patients the whole time, making sure they're doing okay, because you're giving them quite a lot of fluid here. I'll go 40. Your arms are going to get really tired.
Yep.
And then I need another 30. Alright. Questions on what I'm doing?